Hi, good afternoon. I work in the Cayman Islands, and we're quite a small island with similar problems as the rest of the Caribbean, but on a much smaller scale. I'm going to start off by just showing you the number of cases and investigations we had last year in 2014. In total, we had 225 investigations. Over 50% of these proved to be negative, and if we'd known that at the time, it would have saved us a lot of insecticide application and wasted man hours. We only had 16 confirmed local positive cases and over 40 imported cases. Chikungunya, we'd really never heard about it before 2012. We were invited to a conference in Jamaica, and that was really the first we'd encountered this disease. We learned that chikungunya was very likely to be coming to the Caribbean in the near future, and that in the absence of any vaccine, the only effective way of controlling this disease was going to be vector control. We learned that the primary vectors were Aedes aegypti and Aedes albopictus. In the Cayman Islands, we only had Aedes aegypti up until 1996, and then it was eliminated. We were vector-free for 2 years until Aedes albopictus came to the island and moved into exactly the same locations that aegypti had been in. Then Aedes aegypti was reintroduced in 2002 and has now totally displaced Aedes albopictus. We don't find Aedes albopictus anymore. One of the things that was recommended at the chikungunya meeting was that we strengthen our existing control program. We were lucky in that we did actually have an existing control program that had been in place for a number of years. So I'm just going to go over our container breeding control program. As I say, we were lucky in that we already had one in place. It was quite a small program. We only had 16 field workers. Our control was primarily based around source reduction and the application of larvicide when we find containers infested with Aedes aegypti. Due to the short time it takes for this mosquito to develop from larvae to adults in the Cayman Islands, we'd ideally want to be surveying every yard on the island at least once a week. Well, on the island we've got 27,000 buildings, each requiring survey, and 16 field workers to do this. So, in order to carry out a full once-weekly survey of all residences, each survey officer would have to survey each residence 360 residences a day, which wasn't possible. So, we knew we weren't going to get the manpower we needed to survey once a week, so we had to optimise the resources we had. We've been recording all data collected on Aedes aegypti distribution since Aedes aegypti was introduced in 2002. And we're constantly getting the same figure in that 80% of all our larval finds are found in only 20% of the houses. Therefore, we've been using GIS technology to enable us to map all areas that we find Aedes aegypti and use something that we call a targeted approach to controlling the mosquito. With a targeted approach, we analyse the data that we receive. We input the data into a database which is linked to a program called ArcMap, which allows us to produce real-time density maps of where our problems are. So what we do is we have our targeted program. Any yards that have been found to be breeding 3 or more Aedes aegypti in a cycle are selected for once weekly survey, and yards where we're not finding any larvae, they're surveyed less frequently. Using this approach, we've managed to minimise the abundance of the mosquito. Back in 2008, we had a Pareto index of 24, our Pareto index now is about 4.5. Okay, this just shows you the mapping. We're using a program called ArcMap. We have the island divided into 54 areas that are each area can be surveyed in a single day by a 2-man team. Each map contains details of individual yards and land parcels. And the land parcels in each of the survey maps has a unique identifier number, which we can relate back to all mosquito larvae finds that we collect. So as I say, we've got two types of survey. We've got full survey, where all the yards on a given map are surveyed and treated for larvae. With our current resources, it can take up for a month to carry out full survey of any given area. The targeted survey, which is only those yards identified as causing a problem, and they're surveyed and treated on a once-weekly basis. All larval samples that we collect are returned to the lab for identification and data analysis. So we input all the data into an Access database, which is directly linked to ArcMap, and it allows us to generate straight away density maps. And again, the data analysis of the data that we've collected shows that 20% of the yards are responsible for 80% of larval finds. One of the problems we do have is we have no direct field supervision in the Cayman Islands. We have 16 field workers, no field supervisors. So we've had to utilise a system. It's a real-time GPS tracking system where we can see from the office where our trucks are and make sure that everyone's working in the correct survey area. Although the system works well, it's really no substitute for direct field supervision, which is something we're trying to create new positions for field supervisors. So this is just what I'll see on my computer. I'll be able to see in real time where the trucks are, and I can also survey areas that the trucks need to stay in, and if they leave those areas, I'll get a notification saying that the field workers have left the area. Okay, so in 2012, after coming back from the Chikungunya meeting, we reviewed our program to identify the weaknesses so that we could try and strengthen the program in advance of Chikungunya coming. We realised straight away that we were short-staffed. We needed to increase from 16 to 25. Again, we had no field supervisors, we needed at least 2. Our chemical control was entirely larvicide based. There was no adulticide available for Aedes aegypti control. We lacked a strong public education component. And most importantly, in my opinion, was we had no on-island diagnostic chikungunya test. Also, our ground-based control efforts were very labour-intensive, and we had no disease mapping system in place. Okay, so the first thing we did when we got back was to try and improve our public education. So we established a website. We had someone dedicated to school visits. We appeared on radio talk shows, newspaper and television interviews. We gave pamphlets to homeowners. We did try to recruit a volunteer disease prevention network. The idea was it was something along the lines of a neighbourhood watch scheme. Unfortunately, even though we started this public education campaign back in 2012, we reviewed the data at the end of 2013, and it was still the same result. 20% of the yards produced an 80% of the mosquito problem. The next step was to try and target directly those yards that were causing us a problem. So we started to distribute pamphlets that actually told people that they were in a high-risk residence. We gave them advice on specifically how to deal with, we were trying to target residents of, basically one of the major problems in the Cayman Islands is that immigrant workers are living in expanded houses, and the landlords just don't care, they're not maintaining those houses. So we tried to get those people to actually contact the landlords to improve these yards. Okay, our chemical control was, as I say, it was only larvicide based. We'd shown a number of years ago that our Aedes aegypti were resistant to all the synthetic pyrethroids that we tested against them. So we had to carry out resistance tests on a number of organophosphates. We showed that our aegypti were susceptible to both malathion and chlorpyrifos. We selected to go with chlorpyrifos because malathion is known to cause a biting frenzy for half an hour or so after you spray the malathion. mosquitoes that have increased biting rate, which was something we really didn't want to be introducing because chikungunya transmission was going on. Our cage field trials showed that we could successfully use aircraft, early evening applications of mosquito mist, and doing this, in cage trials, we got between 100% and 40% mortality. 40% mortality was achieved even in thickly vegetated areas when we placed the cages there. So we felt that by October 2012, we did have a usable technique for targeting adult Aedes aegypti as well as the larvae. Okay, we've had our mapping chikungunya cases. We didn't have a system in place, but that was fairly easy to set up because we already had a mapping system in place for Aedes aegypti. Okay, so once we heard of the first case in December 2013, we established our planned response, how we would react. We knew at this point it was on its way to us. So we continued to strengthen the weak components of the control program. We petitioned for more staff. Our plan was to continue our routine larviciding operations, which were based around BTI and a chemical called aquatane. And the plan was, once local transmission had been shown to be occurring, we were going to switch emphasis from larval control to adult mosquito control. Our thinking is that although larval control and source reduction are regarded as the best methods of controlling Aedes aegypti, the best method of minimising chikungunya virus transmission in an outbreak situation is to target the adult mosquito. That's where the virus is circulating. Okay, our first case of chikungunya was the 25th of June 2014. A patient had recently returned from the Dominican Republic. We responded by carrying out adult mosquito control operations in a 600-foot area around the residence of the suspected patient. We used mosquito mist applied by the geothermal foggers, and all residences within 1,000 feet of the survey area were treated with larvicides, aquatane and BTI. We didn't get any further notifications of chikungunya cases until July 2014. In July, we got 13 notifications of possible cases, August 19 investigations, and September 31 investigations. Now, for each one of these investigations, we had to send staff out to carry out both adulticide and larvicide control operations on at least two occasions at least 5 to 7 days apart. By September, the high number of possible cases we were seeing meant that we could no longer respond in this way. Thermal fogging is it's not a very nice job to be carrying out, and chlorpyrifos is a particularly nasty chemical that smells, and unless you're wearing the correct safety gear, it's corrosive to tie there. So from September 23rd onwards, we changed our control operations. We moved to a regime of twice weekly area-wide adulticide treatments. All our adulticide treatments were carried out between 5 and 6:30, which was the peak activity of the mosquito, and used chlorpyrifos. We had 3 different treatment methods. We had aerial ULV applications to treat the larger block areas. We had ground-mounted truck ULV to treat more urban areas where towers were a problem. And we carried on the handheld thermal fogging to treat outlying areas. All areas were treated 3 times a week to minimise virus transmission. This is just an example of a wide block area treated by air. You'll see some red areas around them. They weren't part of the block, and they were treated by ground applications. It's another area. These are urban areas that were treated by truck. And we were very successful. Our sentinel trap showed that we reduced the BT sentinel trap count showed we reduced the adult abundance by 80% in the Georgetown area. At the same time we were doing this, we were looking at a trial of aerial BTI applications. the idea was, rather than sending crews around to apply by hand, we would try and target containers from the air. We treated each area once using a BTI WDG formulation, and we evaluated it using the BT sentinel trap and compared Rhetoric disease. We got quite clear results after a couple of months. The untreated area levels remained relatively constant, while there was a significant drop in the treated area. The results, we got a 65% reduction in adult abundance and a 55% reduction in the number of containers we found carbon larvae. And we compared the results by a t-test on the log transform data, and it showed it to be highly significant. Okay, so our plans for 2015, we're still short-staffed. We know we're still at risk from chikungunya because we've only had 16 cases confirmed so far, so most of the population is still susceptible. We're still trying to establish the volunteer network to help us with our control efforts, but there are concerns about accident liability. On-island diagnosis would greatly benefit us. If we could more efficiently target our control operations, I'm sure we'd be able to control this disease better. We are quite happy with the two larvicides we've got, Aquitaine and BTI, both very effective. And our strategy will be the same again this year. Once we've established on-island transmission, we will be using aircraft and truck-mounted foggers. We're also looking at a trial of a new trap called, the idea is an auto-dissemination trap, which I'm sure other people will be talking about at the conference. And we're still hoping to start with that genetically modified mosquitoes. Okay, thank you.